Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left
hand.
For 45 minutes of CPR. We can stop CPR with 600.
So I want you to imagine stepping onto a psychiatric nursing unit or even just into a really busy emergency department.
Right. Those can be incredibly chaotic environments.
Exactly. The fluorescent lights are harsh, monitors are beeping everywhere, and you have this patient sitting on the exam table right in front of you.
Okay, I'm picturing it.
And their vital signs are perfectly stable. Like heart rate is a calm 70, blood pressure is textbook normal. But as they explain how they got that fading bruise on their arm or why they're suddenly getting these crippling migraines, the story just isn't adding up.
Yeah, that happens a lot, actually. You start to see those inconsistencies.
Right. And your instincts as a clinician, or honestly, just as an empathetic human being, they kick in. You recognize the hidden markers of intimate partner violence.
It's a very specific clinical picture when you know what to look for.
Exactly. And your immediate visceral reaction in that moment is to lean in and say, you need to pack your bags. You need to get out of that house tonight.
Which is, quite literally, the single most dangerous thing you could possibly say to them.
Why, really?
Absolutely. I mean, if you give that directive, you might inadvertently trigger the most statistically lethal moment of that patient's entire life.
Wow. Okay, and that counterintuitive reality, that is the exact foundation of our deep dive today.
It really is. It flips everything you think you know about trauma on its head.
For sure. Because today's mission is to decode the hidden signs of domestic and community violence. We are looking at this massive, sweeping national health concern that affects, something like 10 million people annually in the U.S.?
Yeah, the scope is just staggering. It's an absolute epidemic.
And we are setting this up as a high-yield, elite mentorship session. So for everyone listening, our goal is to extract the top 20% of knowledge from the clinical text that will give you 80% of the understanding you need.
Right, the classic 80-20 rule. We want to focus on what actually matters for nursing exams, clinical judgment, and most importantly, safe patient care.
Exactly. We'll be systematically breaking down intimate partner violence, child abuse, elder abuse, sexual assault, and community violence.
It's a heavy list, but it's vital.
It is. I kind of frame this deep dive like learning to read a completely new language, like the language of trauma. It's about seeing those invisible injuries and knowing exactly what to say and, what not to say when the stakes are literally life and death.
That's a great analogy, because treating trauma is not like treating a broken femur or a heart attack. The language operates on an entirely different frequency.
So let's jump right into that 20% that matters most, the absolute high-yield core concepts.
Well, the highest risk of homicide, the absolute peak danger zone, occurs right when a victim attempts to leave an abusive relationship.
Okay, I have to push back on that right away because, our instinct is to tell them to pack their bags immediately. Like, if you see someone in a burning building, you tell them to run.
I know, it feels so wrong to do anything else, but you're dealing with a fundamentally different pathology here.
So why is telling them to leave the most dangerous time?
Well, it comes down to the core problem, the pathophysiology of abuse. It is not caused by anger, and it's not caused by alcohol. It is fundamentally about power and control.
Right, so it's not just a guy who loses his temper because he had a bad day at work.
Exactly. The abuser often has incredibly low self-esteem. They use violence to boost their own ego and keep the victim subjugated. So when the victim tries to leave...
they lose that control?
Precisely. The abuser realizes their manipulation is failing. The leash has snapped. And in a desperate, frantic attempt to reassert dominance, the violence escalates exponentially.
Oh, wow. So they operate on this terrifying logic of, if I can't control you, nobody will have you.
That is exactly the cognitive distortion at play. This is why directing a patient to leave before a comprehensive covert safety plan is in place is a massive clinical trap.
Okay, that is a huge must-know safety risk. That definitely changes how you handle things. But what about the legal side, like the must-know ethical principles?
The biggest one you need to master is mandatory reporting. And this is where students get really tripped up. All 50 states require nurses to report suspected child abuse.
And you don't need, like, hard forensic proof for that, right?
No, absolutely not. You do not need proof. You only need suspicion. If something feels off, you report it to Child Protective Services.
But wait, reporting for adults like intimate partners, that has totally different consent rules, doesn't it?
It does. Because with competent adults, we have to protect their autonomy. Unless there's a specific state mandate, like a gunshot wound, you generally cannot report adult domestic violence against the patient's will.
Wow, that is a really fine line to walk. It feels like you're keeping this horrible secret.
It's agonizing for the nurse. But if you call the police against their wishes, you are just another person stripping away their control. You're violating their trust.
That makes a lot of sense. So, jumping into communication strategies, what is the absolute must-know rule there?
You never tell a patient what to do. You never say, you need to leave him. Instead, you always affirm, believe, and empower.
Affirm, believe, and empower. Got it. And what's a concept that students usually confuse on exams?
Distinguishing between an elder patient's natural deterioration from a chronic illness, like dementia, versus actual active neglect or abuse, it can look very similar on the surface.
Okay, we are definitely going to unpack all of that. Let's move into section 1, the violent family dynamic and intimate partner violence, or IPV.
Right. Because before we look at specific victims, we need to understand the environment where most of this abuse actually happens.
The family unit, which is, shockingly, often the most dangerous place for victims.
It is. So for IPV, the diagnosis encompasses physical, emotional, economic, and sexual abuse.
And the stats on this are just wild. Nearly 1 in 5 women and 1 in 7 men experience severe physical IPV in their lifetimes.
Yeah, and remember, physical violence is usually just the final manifestation of a much longer campaign of control.
Like economic abuse, where they don't let them have a bank account.
Exactly. So they literally cannot afford to leave. And going back to the core problem, it's all about that power dynamic.
You mentioned intergenerational transmission in the outline. How does that factor in?
Well, violence is a learned behavior. Children are basically taking a masterclass in psychological coercion every day if they grow up in an abusive home.
So they see their parents and they learn that violence is just a normal conflict resolution tool.
Exactly. A young boy might internalize that masculinity requires dominance, and a young girl might learn that enduring abuse is just the cost of being loved.
That is so dark. Let's talk about risk factors. Substance use is a big one, obviously.
Right. But again, alcohol doesn't cause the need for control. It just diminishes inhibitions. It takes the brakes off.
Right. They might want to hit their partner when sober, but they're scared of the police. Drink some alcohol and that fear vanishes.
Exactly. And we also need to mention the rise of date rape drugs here, like flunitrazepam or Rohypnol. Abusers use them to induce amnesia and exert total dominance.
Okay, but here is a massive red flag that I found really surprising. Pregnancy. Why is pregnancy such a huge trigger for violence?
Because it's a massive narcissistic injury to the abuser.
A narcissistic injury. What do you mean by that?
Well, the abuser needs the victim's undivided attention to regulate their own fragile ego. When the victim gets pregnant, they're tired. They're focused inward on the baby.
So they aren't paying as much attention to the abuser.
Exactly. The abuser gets insanely jealous and possessive. They view the unborn child as a rival, so they often escalate to physical violence, frequently targeting the abdomen.
Oh my God, that is horrifying. And what about cultural factors, like immigration status?
Abusers weaponize that constantly.
Right.
Non-citizens face severe barriers. The abuser will threaten them with deportation, saying, if you call the police, they'll deport you and take your kids.
So they're completely economically and socially isolated. And the same thing happens in same-sex relationships, right? With the threat of being outed.
Yes. The abuser holds the power to out the partner to their conservative family or their employer. It's a unique weapon of control that keeps the victim paralyzed.
So how does a victim stay in this for years? Let's talk about the expected findings, specifically the cycle of violence.
All right, this is crucial for nursing assessment. The cycle usually has 3 phases. Phase 1 is the honeymoon phase.
Okay, so this is almost like a rigged slot machine, right? The intermittent reinforcement.
That's a perfect analogy. After an explosion, the abuser is flooded with contrition. They offer apologies, they buy gifts, they promise it'll never happen again.
And the victim pulls the lever, hoping for the jackpot, a healthy relationship.
Exactly. But it never lasts. That leads to phase 2, the tension-building phase.
So this is where things get really quiet and scary.
Yes. Stony silence, arguments over nothing, constant complaints. The victim feels like they're walking on eggshells.
Trying to appease the abuser to stop the explosion?
But the explosion is inevitable, which is phase 3, the acute battering episode.
Yeah.
The actual physical or severe emotional violence.
And then it just snaps right back to the honeymoon phase. So, as a nurse, what is the absolute priority assessment here?
The golden rule. You must assess safety alone. You ensure the partner is not in the room.
Because if the partner is there, the victim will never tell the truth.
Exactly. And you don't ask vague questions, you ask specific screening questions. Like, do you feel safe in your relationships?
And for NCLEX and exam logic, they love testing this, right?
Oh, absolutely.
Yeah.
The priority action is always separating the patient from the suspected abuser first. You invent a clinical excuse, like needing an EKG or a urine sample just to get them alone.
And you never confront the abuser directly.
Never. Because they will act charming to you and then severely punish the victim the moment they get to the car for making them look bad.
Okay, that makes total sense. Let's transition to section 2, because if the environment is built on power and control, the most powerless people in the house are the children.
Right. We are moving from partner violence to child maltreatment.
So what are we looking at here, diagnosis-wise?
It includes intentional physical injury, sexual abuse, psychological abuse, and most importantly, neglect. Neglect is actually the most prevalent type, making up about 78% of cases.
Wow, almost 80% is just neglect, not providing food or shelter. And fatalities are the second leading cause of death in children under 1 year.
It's devastating. And the core problem here is that parents who abuse often have minimal parenting skills. They're emotionally immature themselves.
And they kind of view the children as property, don't they?
Yes, or they have these wild, unrealistic expectations. They subconsciously expect the newborn to provide the unconditional love they lacked in their own childhood.
But a newborn just cries and needs things.
Exactly. So when the baby cries for 6 hours, the fragile fantasy shatters, and the parent uses violence to silence them.
So what are the expected findings? Clinically speaking, what are we looking for objectively?
You're looking for highly specific physical markers, like stocking and glove distribution of burns.
Wait, what does that mean, stocking and glove?
It means a perfectly straight line of demarcation around the wrist or ankle. It indicates the parent forcefully held the child's limb in scalding water.
Because an accidental spill would have irregular splash marks?
Exactly. You also look for cigarette burn shades or bite marks. But the biggest red flag is developmental mismatches.
Right, this is huge, like a fractured femur in a 2-month-old.
Yes, a 2-month-old cannot physically generate enough force to snap their own femur. So if the parent says, he rolled off the sofa...
You know it's a lie. It's a biomechanical impossibility.
Precisely. Or contracute brain injuries, which we often see in shaken baby syndrome, explained away as a minor bump on the head.
The internal physics just contradict the story. And for sexual abuse signs?
High incidence of UTIs and advanced sexual knowledge or behavior that is completely inappropriate for their age.
So what is the priority nursing assessment when you see these red flags?
You look for inconsistencies. Does the parent's story match the severity of the injury? Does the child's story keep changing?
And here is a huge nursing intervention rule. You do not interrogate the child.
Absolutely do not interrogate them.
But the human instinct is to drop to your knees and ask, who did this to you? Why is that wrong?
2 reasons. 1, rapid-fire questioning in a scary hospital will traumatize them further. And 2, legally, children are highly suggestible.
So a defense attorney could argue the nurse planted the memory.
Exactly. The abuser goes free because you asked leading questions. Instead, for young children, we use play therapy. Puppets, anatomically correct dolls.
You just observe them playing out the trauma. So what about the legal side, mandatory reporting?
You have an absolute legal duty to report to Child Protective Services, and you can do it anonymously.
And again, you just need suspicion, not proof.
Correct. For NCLEX logic, questions will test your ability to spot those injuries that don't match motor skills, like that 2-month-old rolling off a couch.
Right. The correct answer is to report, not to investigate.
Always. Let's move to section 3. Just as children are vulnerable because they depend on adults, older adults become vulnerable when chronic illness reverses that caregiving dynamic.
Right, elder abuse. This is a massive hidden issue. Maltreatment of older adults affects, what, 1 in 10 people over age 60?
Yes, and it includes physical, psychosocial, material, and financial abuse, neglect, and self-neglect.
What's the core problem driving this? It's not usually the same narcissistic control as IPV, right?
No, it's frequently driven by extreme caregiver burnout. You have a family member thrust into 247 care, For someone with severe Alzheimer's.
They're exhausted, broke, and isolated.
Exactly. And without support, that exhaustion warps into deep resentment and eventually abuse. Also, spousal abuse might suddenly emerge late in life if a disability makes one spouse totally dependent.
So what are the expected findings for material abuse?
It's all about a paper trail. Unpaid bills, even though the patient has an adequate pension, signatures on checks that look completely different from the patient's normal handwriting.
Or missing valuables. And what about neglect?
Active neglect is brutal. It's the smell of urine or feces because they aren't changing incontinence briefs. Untreated bed sores, missing hearing aids or glasses.
And what are the red flags regarding the caregiver's behavior in the clinic?
They act as a gatekeeper. They won't let the older adults speak for themselves. They complain constantly about the cost of medications.
Okay, this brings up a huge safety red flag concept, differentiating self-neglect from competency.
This is one of the hardest clinical judgments.
So, say you have an 80-year-old patient squandering their life savings on a charity that their family hates. Is that self-neglect?
No. Assuming they pass a neurological exam, they are competent. And competent adults have the absolute right to make terrible, foolish decisions.
Right. We can't medicalize bad financial choices. So what is actual self-neglect?
It's the true inability to manage activities of daily living, or ADLs. Living in vermin-infested quarters, wandering onto a highway, severe malnutrition because they forgot how to chew.
Got it. It's a physical or cognitive failure, not just bad choices.
Exactly. On the NCLEX, you have to distinguish between natural deterioration from dementia versus actual abuse.
Look for hidden injuries or a caregiver who refuses to step out of the room.
Precisely. Now, moving to Section 4. Violence doesn't just stay in the home. When it hits the community, it often takes the form of sexual assault.
Which is profoundly misunderstood by society.
Extremely. So the diagnosis of rape is the perpetration of sexual intercourse against a person's will. And this absolutely includes date or acquaintance rape, which is huge on college campuses.
So what is the pathophysiology here? Because people often think it's a crime of uncontrollable passion or sex.
And we have to loudly clarify that ultimate truth. It is absolutely not a crime of sex. It is the exertion of power, control, and the infliction of punishment.
The sexual act is just the weapon chosen for domination.
Exactly. And historically, the legal system completely failed here. I mean, it wasn't until 1982 that a man was successfully convicted of marital rape in the U.S.
Wait, 1982? That is insanely recent.
I know. The law basically viewed a marriage contract as permanent, irrevocable sexual consent. It took massive feminist legal pushes to change that paradigm.
Wow, okay. There are so many myths around this, like the idea that it usually happens with a stranger in a dark alley. What does the data actually show?
The data obliterates that myth.
Mm-hmm.
Most rapes are highly premeditated. They occur near the victim's home, and the perpetrator is overwhelmingly an acquaintance, a friend, or an intimate partner.
Someone they had reason to trust. That makes the psychological trauma so much worse.
It does. So let's talk about the priority nursing assessment when they arrive in the ER, the emergency protocol.
Because they just want to wash it all away, right?
Yeah, that is their absolute first instinct, but preserving evidence is paramount. The patient should not shower, they shouldn't brush their teeth, douche, or change clothes before the forensic exam.
That is agonizing. You have to ask them to sit in their trauma.
You do. If they report no oral sex occurred, rinsing the mouth is okay, but otherwise they have to wait for a sane nurse, a sexual assault nurse examiner.
And what are the specific nursing interventions during this time? Empowerment is huge here.
Yes. Give control back. Let them decide who to call, what to do next, and whether they want to press charges. You must get explicit signed consent for every single photo or hair sample taken.
And for medications, this is a highly testable area.
You administer prophylactic treatment for STDs, like broad-spectrum antibiotics. You initiate HIV testing, but you have to explain the window period.
Right, because the negative tests that night doesn't mean they're safe.
Exactly. Seroconversion takes time. You might start them on PEP, post-exposure prophylaxis, but you test again at 6 weeks, 3 months, and 6 months.
And emergency contraception like Plan B?
Yes. And you must clarify for the patient that this prevents conception by delaying ovulation. It is not an abortion pill. It stops a pregnancy from starting.
That's a crucial patient teaching point. For NCLEX logic, they will test on preserving evidence, don't let them shower, and requiring that signed consent.
Always focus on patient autonomy in those answers. Let's move to Section 5, the need for power and control trickling down into our schools and digital spaces.
Right. Community violence, bullying, and hazing.
So this encompasses school violence, cyberbullying, ostracism, and hazing.
I find ostracism really fascinating because ignoring someone doesn't sound as bad as physically hitting them, but the damage is catastrophic.
It goes back to our evolutionary neurobiology. Being excluded from the tribe used to mean literal death. So when a kid is ostracized, their brain processes it as a mortal threat to their existence.
It lights up the exact same pain pathways in the brain as physical trauma.
Exactly. It can cause profound depression and anxiety. And then you have hazing, which weaponizes that exact desire to belong.
Right. They lure students in with the promise of prestige.
Yes, they use sleep deprivation, forced alcohol consumption, isolation. The victim endures it because they think they're buying safety and brotherhood.
And the trauma responses to community violence in general are massive. The source text had a staggering statistic. Post 9/11, there were 532,240 cases of PTSD in the NYC area alone.
Over 500,000 people. It shows that you don't have to be physically injured to sustain deep neurobiological trauma. The whole community's baseline of safety is shattered.
So what are the interventions for that?
School curricula focusing on anger management and conflict resolution.
Yeah.
And immediate crisis counseling deployed right after public tragedies to prevent that PTSD from calcifying.
Okay, we are in the final stretch. Section 6, therapeutic communication and the nurse's self-awareness.
This is arguably the most important tool you have. It's high-yield NCLEX gold. Let's start with the don'ts.
What's the biggest mistake a nurse can make?
Don't tell the client what to do. Never direct the client to leave.
Because it strips their autonomy again.
Exactly. Next, don't preach, moralize, or express outrage at the perpetrator.
Hey, why not? If I say, your husband is a monster, doesn't that show I'm on their side?
It shifts the focus onto your emotions instead of the patient's. And because of trauma bonding, the victim might actually instinctively defend the abuser, shutting down the whole conversation.
I see. You have to stay neutral and grounded.
Yes. And the final don't. Never recommend couples counseling for IPV.
Because it's dangerous.
Highly dangerous and totally ineffective. The abuser will just punish the victim later for anything said in therapy.
So what are the Davis?
You affirm. You say, I am sorry you have been hurt. You say the abuse is absolutely not your fault. And you help them develop a safety plan when they're ready.
But doing that requires massive self-awareness from the nurse. I mean, hearing these stories, seeing the injuries, it induces horror.
It takes a huge emotional toll. You will feel revulsion, but you have to contain those feelings because if the patient sees disgust on your face, they will internalize it.
They'll think you're disgusted by them.
Exactly. Your radical acceptance of them is the first step toward their own self-acceptance.
That is incredibly powerful. Let's wrap up with a quick summary of the 80-20 rule.
Right. Safety first, always assess alone. Recognize the hidden signs and developmental mismatches. Preserve forensic evidence. Empower the patient's autonomy, and intimately know your mandatory reporting laws for children versus adults.
Perfect. I want to leave everyone with a final provocative thought. It's about identity and healing.
Oh, this is a great concept.
Right, because the legal system calls them a victim, which is necessary for a trial, but therapy calls them a survivor to emphasize their strength.
But the reality is that healing is fluid.
Exactly. A person might feel like a survivor on Tuesday and then get triggered and feel totally victimized again on Wednesday.
The pendulum swings constantly.
So your job as a nurse isn't to label them. It's to meet them exactly where they are in that moment and hold the space for them to reclaim their power. So what can you do in your own community to make that safe space a reality?